Thanks for joining today. I'm going to speak about psychological birth trauma. We're going to begin by hearing from women who have experienced birth trauma. We're going to talk about risk factors and how to identify the person who might be at risk of experiencing it. And then finally, we'll talk about trauma-informed care, a universal approach to high-quality care that can reduce the risk of trauma in all of our women.
No one wants to know about birth trauma.
Almost 4 years on, I've only just started talking about it honestly.
I felt a lot of rage towards my partner because he didn't have to go through what I had to go through.
Although the trauma affected me both physically and psychologically, it was the psychological impact that affected me the most.
The birth of our little girl was in October 2015. I was 35 years old.
I was 38 and it was in 2017.
I experienced a birth trauma at age 30 in 2018.
I was 29 years old when I experienced birth trauma as a first-time mum.
And I suffered a traumatic birth with my first child in 2015. I was 33 years old.
About 2 or 3 weeks after birth, I could feel the prolapse. The physical pain is still here every day.
The impact it had on me was both physical and psychological. And until I got my diagnosis, it put a lot of strain on my relationship with my husband as well.
My birth trauma has impacted every area of my life.
I developed insomnia where I would have post-traumatic stress flashbacks where I would lie down and I would feel like I was back there again. I would feel like I was on the operating table again. Prenatal classes that I attended focused almost completely on natural birth and non-intervention birth. So when it came to having a vacuum forceps delivery, I really didn't know what I was in for.
There was not enough information provided during my pregnancy about the impacts a birth can have. It's all about the logistics.
The classes I went to were very much led by what the new or expecting parents wanted to know about, and no one wants to know about birth trauma.
I wasn't told what was going to happen and I wasn't given the opportunity to say I didn't want that to happen.
As a society, I don't think we support our mothers well enough, and I don't think we talk about birth trauma well enough.
Around a third of women describe their birth as being traumatic, with the presence of some post-traumatic stress type symptoms. And although the incidence of true postpartum post-traumatic stress disorder is much lower, it is potentially ameliorated by the actions of staff and how we look after women in the perinatal period. The diagnosis of PTSD requires the presence of 4 specific symptoms for longer than 1 month and the presence of a clinically significant distress or impairment of daily functioning. I want to talk about an article that reviewed the literature in relation to factors associated with the development of birth trauma. As you can see, it spanned quite a large number of countries, and I will concentrate on the Australian perspective shortly. In the study, they looked at pre-pregnancy risk factors for trauma. They then mapped through the pregnancy, antenatal period, intrapartum, and what happened postnatally to try and find out what aspects associated with that pregnancy and birth were linked with birth trauma. There are 7 main risk factors, and the presence of previous psychological trauma, and in particular complex trauma. Complex trauma has a specific meaning in psychological terms, and I'll talk a bit more about that later. Having a pre-existing diagnosis of either anxiety, depression, or other mental health disorder is a significant risk factor too. A high-risk pregnancy in the antenatal period, unexpected caesarean section, vacuum or forceps birth, and the presence of fear about the baby's well-being in the perinatal period. Finally, low social support and the presence of depressive type symptoms in the postnatal period were risk factors for the development of birth trauma. There are protective factors, and antenatal education is important. We heard before from women who valued the presence of education about unexpected outcomes and what that might mean, and allowing them to process them when they did occur. Continuity of care provider is important, and constant access to the baby in the early postnatal period. The Australasian Birth Trauma Association have some good information for women. They have run CPD sessions in the past for health professionals. I attended one in Brisbane last year. It included obstetricians, midwives, pelvic floor physiotherapists, urogynecologists, and really their information is definitely useful for women who have experienced birth trauma. They do also offer a peer-to-peer program where trained women with birth trauma can support others in a safe way. So what can we do about this? I reached out to ABTA and asked permission to post these questions on their social media site, and I got a significant number of responses that I'm going to share with you now. When analysing these, I broke down the themes of care into the various antenatal, intrapartum and postnatal periods. People want to hear more about everything. There is a tension, of course, between giving people too much information about having not enough time to be able to cover it all in adequate detail. And I know that Queensland has guidelines on what's included in antenatal care education sessions. These, of course, have to deal with that tension and make sure that that time is used appropriately. Having said that, women have the ability to receive information in ways other than the short antenatal visits. They can be given links to information to read. We can give much more directed information. So if you're offering somebody an induction of labour for a large baby, the information they need about, for example, perineal care or forceps and vacuum birth, given that they're much more likely to have complications, would be probably more in depth than it would be for somebody who's had a vaginal birth before and is otherwise low risk. Informed consent is something that came through consistently, not just in the antenatal period, but the same thing around adequate information to make the decisions and for us to understand what is actually important for people. As we know, pregnancy and birth can change quite quickly, and one of the problems with having a fixed mindset about the outcome is that, of course, when things don't turn out like that, there can be psychological consequences afterwards. Forceps births do have specific risks, and a comment like this doesn't necessarily reflect that all women would refuse forceps if they knew about them. What it reflects more clearly is that women want information about the types of births that they could be exposed to. Clearly, if you have a mid-cavity birth and there is the option between forceps or caesarean section or forceps and vacuum, then that kind of conversation needs to take place. If a vacuum has just failed and the baby's on the perineum, then a forceps would be much more appropriate, and no woman would deny that was the right way to go, rather than a very traumatic caesarean section for themselves or their baby. But the point here is about actually having the information and being involved in the consenting and the informed choice. Feedback about empathy from staff members is consistent not only in this survey, but also in many patient complaints that I've seen over the years. When staff do not treat their patients with empathy, it leads to significant patient distress and ultimately complaints and even litigation. An empathic approach is particularly important in obstetrics because not only are we dealing with the physically intimate environment of a vagina, but often the birth process and the examinations can reopen up old psychological scars. I think the comment here outlines the clear difference between physical and psychological birth trauma, and I think we've all been guilty of making the assumption that if it was a normal birth, then everything must be okay. When we see women early in the postpartum period, it's important that we ask these questions. We need to make a connection to them. We need to ask them about how they're travelling at the moment. And if we begin with our agenda, then we lose that opportunity for connection, and we might never find out actually what happened or how they're thinking. One of the key criteria for the diagnosis of PTSD is actual or belief that your life was in threat. And although for us a postpartum hemorrhage may be common, particularly low-level ones, these are genuinely life-threatening circumstances to many women. And it can take some time to properly unpack this and reassure them in a way that keeps them psychologically safe once they go home. For many women, the 6-week postnatal check is much more baby-focused than it is about debriefing about the birth process or exploring women's needs at that time. The midwifery group practice model absolutely does this much better, and the debrief is more than just a single visit and is something that's carried out over time. I think in Australia there is some difficulty getting back into the system to explore those things if they need to be explored, and even accessing psychological support afterwards requires the strength to go and visit a GP, to get a GP mental health treatment plan organised, and to do psychology sessions, all in a time when you've got a new baby and everything is already too hard. You can see how it's very simple or preferable for women to box this up and not address those issues. We've all heard the implication that, well, if you've got a healthy baby and you're doing okay, then you should be happy. But are you really well if you're not psychologically well? And are we as care providers so unambitious that we're aiming at the lower levels of this pyramid rather than the higher ones? I think we can do much better than that. I've mentioned already the Australasian Birth Trauma Association and the information they have on their website for consumers and for health professionals. The peer support program mentors undergo selection and training, and they conduct their peer support through telephone conversations. We've been using the word trauma to indicate trauma that's occurred either physically or psychologically around the time of birth. And what I'm going to talk about for a while now is trauma-informed care. Trauma in this context is really about trauma that's occurred, particularly when an individual is a child. And the specific type of trauma called complex trauma means when a child has been exposed to more than one occasion of specific types of traumatic incidences, which go on to affect their behaviours and capabilities as an adult. This is a graphic from the Children's Hospital Queensland, and it outlines a description of what are known as ACEs, and something that I hope you've heard of before. ACEs have been studied quite extensively, both in terms of their number and the consequences and effects on individuals and populations. As you can see on the slide, and I won't read out each of the ACEs in turn, an individual that experiences a singular adverse childhood experience copes very differently to a child who may have experienced multiple experiences. The trauma of one may be managed quite well, but once you have multiple traumas, they all interact with each other, and the ability of the child to respond and develop a positive response is significantly compromised. As you can see here, the effect of ACEs on future outcomes in terms of morbidity and mortality isn't small. These aren't things that people are going to present and tell you. They're not going to say, I've got 4 ACEs. Clearly they're not. But when I see patients in clinic or when I see them on the ward, I want to review preceding notes, visits with social work, who was involved in previous pregnancies, to try and draw out an understanding of that individual's risk of being affected by adverse childhood experiences and what they might need from me in terms of how I interact with them. As you've seen, the health consequences of adverse childhood experiences are quite significant, and as you might imagine, the cost of them is inordinate as well. Australian research puts it at about $24 billion per year, so this is obviously a substantial amount of money. It's something that we may not directly have a great deal of control over, but we can certainly avoid re-traumatization, and we can provide the patients with the type of care that they need at this critical time when they're exposed to something as intimate as childbirth. There are Australian national guidelines on how to care for people who might have been affected by trauma, in particular complex trauma. The Blue Knot Foundation released these. They help guide individuals. They guide health practices such as GP surgeries, and there's also maternity care guidelines in how to provide optimal trauma-informed care during the birthing process. Gerber's publication in 2019 outlines in some detail how we can provide an environment of safety, one of support, one of where the individual can grow and build resilience. And this is really what trauma-informed care is about. Bringing calmness to situations can be more tricky on the birthing suite than it is in antenatal clinic or other environments. We often need to be able to have an awareness of our own inner physiology so that we can calm ourselves before we enter the situation, or as we feel ourselves becoming more heightened, actively calming ourselves down, breathing more slowly and bringing a calmness to the people around us. An understanding of trauma and its effects and the needs of the people who are affected by trauma is something that you can learn through reading, and it's something that I think we all have a responsibility to have an awareness of. I mentioned before about reading through notes and getting to understand about a person before we meet them. And the importance of this is not only so that we show continuity of care, but it's also about having an understanding of the timing of when we might ask the difficult questions, if at all. And often we need to build trust before we are in a position to be able to ask complex questions about childhood experiences, for example, or abuse or other issues that we know are going to be fragile for that individual. When we earn trust by taking it slowly, by bringing calmness to the situation, then we are containing their emotion. We're containing the trauma response that they are likely to exhibit because of our presence. There's a real compassion and empathy to be able to create a space where an individual can talk about their traumatic experiences. This can be done through active listening, through normalization of their experiences, and giving them time and space to be able to do it at a pace that they're comfortable with. Finally, trauma-informed care is about resilience building, about helping individuals identify those positive social connections and resources within their lives that can help them move forward in a positive way. Sometimes this involves external agencies treating mental health and other issues that have arisen, but the whole package is really about how we care for people, but also how we help them care for themselves. So finally, just to summarize this introductory talk about birth trauma, first of all, it's not about us. And sometimes it feels about us when women tell stories that talk about their experiences in our care, and it's hard not to take it personally. But hopefully the broad discussion about adverse childhood experiences helps you understand why some people come into our service with vulnerabilities that make it very, very difficult not to be traumatized. That the importance of antenatal preparation in terms of information about these complex procedures that might occur, but particularly ones that where there's not going to be much time to have a conversation. Debriefing afterwards, super important, understanding the woman's perspective in the early days, and then finally afterwards trying to lock them into services that you think they may need. Trauma-informed care is a universal precautions approach. We don't know who is affected by complex trauma, and so ultimately we provide it to everybody so that everybody has the best chance of healing when they leave childbirth, even when they've had unexpected experiences that could potentially cause harm. Thank you very much for listening, and I will leave a link to some resources where you can read about all the stuff that I've posted on the slides. Thank you.